Well, good afternoon, everybody, and thank you for joining us today. And of course, your interest in traumatic brain injury and the physical health conditions associated with TBI. Just want to go through a couple of housekeeping items with you as we get going. We do have several panelists to share with you some information today. And we'll also have the ability to do some questions where you can toss them into our Q&A. Just know that this session is being recorded, and we're also offering this session as closed captioning, right? If you don't need the feature at the bottom of your screen, you can simply hover over the live transcript and click hide if you don't want the subtitles. We ask that as you interact with questions that you don't share any sensitive personal information, personal health information during our session today. Our partner staff, of course, are here and available for individual calls, specific issues that you may want to discuss. And if needed, we can schedule some one-on-one time being in contact later. We will also share with you a PDF file via email, a slide deck of our presentation today. Now, in terms of the Q&A, right? So if you would, you can look at the bottom of your screen and you'll see the little icon for Q&A. Please feel free at any time to put questions in there. If they are directed at a particular speaker, go ahead and put their name in there so that we know who to direct that question to. Our hope is to respond to the questions as best we can live. So hopefully we'll be able to share some detailed information with you live, and rather than getting a typed response. Okay. We will moderate and answer the questions at different times throughout the session. We'll also have some question period where I will have an opportunity to moderate the questions and or ask some questions of our presenters today. All right. So with all of that information, you can also raise your hand if you want during the session. And depending upon the Zoom account that you have, you may find that raise hand feature at the very bottom of your screen again at the menu, and it's called reactions. And in that, I know it sounds like third grade, raise your hand, teacher, I want to say something. But you can certainly raise your hand there. And what'll happen is Beth Brooks, she will see the hand and then at the appropriate time, give you permission to come off mute there and share your question. And then hopefully that will have an answer for you, a response for you based on that conversation. Okay. So if there's anything else, you can put something in the Q&A and we'll try our best to respond to that. We do have an agenda, and so we're going to go ahead and get started with that. And our first presenter today is dealing with common conditions and symptoms of physical health related issues, and that's Kara Naronha. I may have messed that up. It's Kara, I think. Thumbs up there, right? Okay. And so Kara is a physical therapist and also a certified brain injury specialist. She's the clinical coordinator of inpatient at Carolina's Rehab in Charlotte, and administrative manager of the brain injury program, also a board member of the Brain Injury Association of North Carolina. And you may hear us refer throughout today the Brain Injury Association of North Carolina as BIONC. And so if you're unaware of what BIONC is, there's your answer. All right. So with that, we're going to go ahead and get the presentation up for Kara, and I'll let you take it from there.
Thank you, Ted. Again, my name is Kara. I'm located in Charlotte, North Carolina. And Ted mentioned that I help oversee the CR Charlotte Inpatient Brain Injury Program. I've been practicing for about 11 years and with Carolina's rehab kind of that whole time. And on the brain injury that whole time. So this is kind of my passion. This is what I get to help coordinate and provide services for patients with traumatic brain injury. So thank you for having me and allowing me to speak today. All right, so I pulled some slides just from our typical brain injury education series that we offer. When patients are with us, they are typically with us for an average of 12 to 14 days. And while they're here, we like to go over some of these common symptoms that a patient with brain injury might experience. And we typically have patients, family members, caregivers, friends, anybody who is involved in that rehab process for the person with brain injury attend this class. So the things that we like to touch on and that are so important in understanding the impact of brain injury are physical implications, cognitive implications, behavioral, and emotional. And we'll kind of dive into some of those. So physical changes, and these are probably the most common symptoms that are recognizable by the general public. So if we are walking on the sidewalk, walking our dog, and we see somebody with a physical impairment, that's going to trigger our eye to recognize that maybe something else is going on. So muscle weakness, coordination, patients may suffer from something called ataxia, which is just a different way of moving. They don't have smooth movements when they are maybe progressing their legs or swinging their arms. Motor planning deficit, fatigue, balance problems, dysphagia, and dysarthria. So when an individual with a brain injury is in rehab with us, some of the things on the right are what we work on to kind of progress them back towards what their goals are. So a lot of exercises to improve strength, a lot of exercises to look at coordination of movement, tolerance to activity and stimulation, improving posture, swallowing and speech exercises. And these are all going to look different for every single different individual with brain injury. Okay. Cognitive changes. So again, these are some of the changes that might not be as apparent to the passerby or somebody who's initially meeting somebody or an individual with brain injury. But a lot of individuals who have suffered a brain injury can have impacts on attention and concentration, language impacts, learning and memory recall, planning and organizing problems, and then problem-solving issues, including insight and judgment. So what we do in rehab is working on reorienting the patient to be better able to kind of function daily while they're trying to learn some of these things. So memory folders are one of our go-to things that we use, and that is just has a copy of the patient's schedule, and after each session is done, we write down exactly what they've done. This is a great tool to use, especially when they discharge from home or discharge to home, just to kind of make sure that they remember what they've done. It's also a great way to communicate with family and friends of what the patient has accomplished if they're not able to remember to talk about. We have speech therapists who work on swallowing and using their voice. We go over a lot of safety awareness, instruction, and education. And then we have different things like problem-solving worksheets and different scenarios to address kind of the insight and problem solving. And we like to make these things as real world as possible. So if we get the opportunity to walk next door to Panera, we might do that to work on money management, interacting in a busy, crowded place, and other situations like that. Next. Behavioral changes. So there can be a lot of behavioral changes following a brain injury. There is a scale that we commonly use called the Rancho Los Amigos scale. And that is a scale from 1 to 7. 1 to 3 is typically what we would think of as our disorders of consciousness patients. And these are patients who are really low level they appear to be comatose, so they're not responding in your typical way that you think somebody would respond. Rancho level 4 is our fun, excited stage of agitation. So this is usually when a patient is kind of emerging from the lower level stages and maybe really does not understand what's going on, and it manifesting itself and coming out as inappropriate behaviors. And then as the patient progresses through 5 to 7, they appear to have more normal behaviors, but oftentimes need a lot of structure. So for inappropriate behaviors, we use a lot of redirection during our sessions to bring the patient back to what we really are trying to focus on, maybe redirect them from any kind of negative behaviors that they're showing. For impulsivity, we really like to use as many things outside of restraints as possible. So we have something called an orientation support protocol. That's for our patients maybe who would appear impulsive, but they're impulsive because they don't understand what's going on. How can we better help orient them, bring them back to the situation? We have kind of decreased stimulation areas. So we actually have a quiet gym in our rehab facility just for patients with brain injury so that they don't have to get overstimulated by the environment. And then confusion and confabulations. And that's just really working on, again, orienting the person to where they are and what they're trying to do. And we do that through redirection. We do that through using consistent therapy staff and through kind of all of our just daily protocols for patients with brain injury. Next. Emotional impact. Again, this is another huge impact that brain injury has on individuals, but again, it's not a physical one that can be seen per se, so it's just something to always remember. But emotional lability can be an issue. So sometimes you can have somebody who laughs at inappropriate times or maybe cries out at inappropriate times. They also are going through the grief process. So they typically, if they've moved out of post-traumatic amnesia, which is that period of time after an injury where you don't recall things, once they move out of that, then they're processing their new normal and what that looks like for them. And that can really bring on some anxiety, bring on depression. So it's important to make sure that these people have resources. We have a wonderful psychotherapist who works specifically with our brain injury team to make sure that they are all able to receive those services. Emotionally also, they may be dealing with role changes. So if somebody's had an injury, maybe they were the primary financial breadwinner for the family, or maybe they were the caretaker and now they have to be taken care of. That can be a pretty big challenge and can result in loss of self-identity. And then just the overwhelming fear of not knowing what the future looks like. And so we do a lot of education about taking recovery one day at a time to really allow people to be present kind of where they're at and take away some of those fears of the unknown. Next slide. So just a little bit about our rehab process and about Atrium Health. And you can go to the next slide. So our rehab facility services typically about 24 patients daily with inpatient rehab, and we are an inpatient rehab hospital stay, so the patients are staying with us. We do have an outpatient program that we share a gym with, which is kind of nice, but this program is designed specifically for people who've experienced a brain injury. And we're really trying to get those patients back to a better quality of life and back to increasing their independence with mobility, with being able to get around, and with functional ADLs. So those are activities of daily living. And we do this through skilled therapy. So we have a team of certified brain injury specialists, of occupational therapists, the psychotherapists, like I mentioned, physical therapists, speech therapists, recreational therapists, and everybody who works kind of in our area who are certified to understand interacting with those with brain injury. So these are some of the people I mentioned. Our patients receive anywhere from 3 to 4.5 hours of therapy a day, which if you think about it, that's a lot. That's like working out for 3.5 or 4 hours a day. And I would guess that most of us don't do that. We do have the scheduled day out every morning. So they do have some routine, and we can kind of cater the patient's schedule to what they need. So if they need a rest break at certain times, if they need a water break at certain times. And then one thing that I really didn't go through in detail here is we have worked really hard to create some meaningful groups while they're here. So we've worked with the Love Your Brain Foundation to offer a yoga class that's tailored specifically to those with brain injury. We have a daily self-reflections group. So a group of appropriate individuals can kind of sit together and just reflect on how their day went and what they're grateful for. We've started a new nutrition group that works with an OT and a speech therapist and the dietitian to make sure that individuals are receiving adequate nutrition and what they need to help in their recovery. So a little bit about how patients and families can be involved, and we love to have patient family members and or friends be involved in the rehab stay, but we always say to ask questions. So if they don't understand what's going on, ask us why we're doing what we do. One thing that's so special about the rehab setting is really ensuring that our families feel comfortable bringing their loved one home and providing the resources that they need once they're home. So we do a lot of hands-on education throughout the day. And then a big important aspect of what we do is setting up the patient for what their new routine looks like once they've discharged from us. So we make sure that they have support groups that they can tap into and that loved ones have support groups. We make sure that they have all their equipment needs that they need at home to successfully, independently, maybe get around. And then we have a ton of other resources that, including the Brain Injury Association of North Carolina, that we put them in touch with just to make sure that we've created a good network for them once they've gone home. These are just some things that we use for them while they are in rehab. So like I mentioned, that memory notebook, which I know some of us can, I use my Outlook kind of like a memory notebook to keep me oriented and going through the day. Encouraging call, don't fall. I think the biggest thing to take home is that we really do try to provide low stimulation environments to promote the healing environment that we want. So maybe lights off, blinds closed, no TV or radio that could be distracting or overwhelming for a patient. And then just really educating the family members and loved ones and or friends to be the patient's advocate. So we provide an educational notebook for each patient about brain injury and about many different aspects of brain injury that we ask that they kind of go through while they're there. And then we offer a support group while they're currently with us to kind of go over some of those questions, but also give them a chance to ask good questions. Thinking ahead, again, like I mentioned, is a very important step for us. So making sure that the patient has what they need to return to whatever they were doing before the injury. So we do have a cognitive education specialist who coordinates with us, and anybody who was in school during their injury, she will come and kind of do an assessment. She is a Mecklenburg County employee and works with them to kind of come up with a plan for school reentry if applicable. We have driving evaluations in our outpatient setting. And then we have great contact with our voc rehab groups. So we can get that process started while they're with us to hopefully be kind of seamless once they get home. Any questions?
So Cara, this is Ted again, and currently there are no questions in the chat or the Q&A, excuse me. And so anything else, final thoughts?
No, we always love to talk about our program. So if you guys have any specific questions about what we're doing at Carolina's Rehab, please do not hesitate to reach out to me. Ted and everybody else has my email, and we're more than happy to show you around, even if you wanted to come see our new hospital. So don't hesitate to reach out if you have any questions.
Absolutely. And thank you, Cara, for sharing what you did with us. Again, that's why we're here, right? To learn what is out there and what to do. So along that way, we do have a couple of individuals here specific from the Brain Injury Association of North Carolina, Beyond, right? And tell you a little bit about them. We have Brad Blackwell and Alicia Street. And Brad, he's been with Bianc since the beginning or thereabouts of 2023 as a statewide trainer coordinator. And he works to educate individuals who are thriving with brain injuries, their families, of course, the professionals. And during his time with AmeriCorps and Vista, Brad developed what he refers to as an unquenchable fervor to continue to dismantle systemic and institutional barriers that act as a conduit through which the shameful condition of social and economic inequities exist. And so my kudos to you, Brad, for engaging with that. Alicia Street, she is also with Bianc as an outreach coordinator. She has a background that's close to my heart, and that is working with veterans with TBI and PTSD and gaining housing and other resources in the Charlotte area. So again, kudos to you, Alicia, for what you do and following that calling. So I believe first we're going to hear from Brad. And so Brad, I'll let you take it from here.
Ted, I'm going to do some slides and then Brad's going to follow up.
Okay. All right. That sounds good. You guys flip that over however you need to.
Okay. Thank you, Ted. Yes, I'm Alicia Street, and I'm here to represent Bianc, or Brain Injury Association of North Carolina. I am an outreach coordinator, like Ted said, and my passion is to get the word out, and that's exactly what I'm here to do for Bianc. We need to raise awareness about brain injury. It definitely does not discriminate, and I'm here to definitely be a voice. I wanted to talk about how brain injury is already considered the silent epidemic. That means, there are little or lack of awareness in our culture about what brain injury is. There are several misattributing symptoms, like they're attributed as character flaws, coping, mental health, substance abuse, courts or justice system involvement. To give a little more, insight on the misattributing symptoms, we also do CIT trainings for first responders, for instance. We have to talk to first responders on, there might be different behaviors associated with brain injuries versus someone being perhaps intoxicated or having different behavioral issues. So that is an example of what we try to be a voice for, so we can, make first responders and, other people aware of, that there is sometimes brain injury going on and how to screen for that. So next. We also want to talk about, what does brain injury even look like? Like I said, it's a silent epidemic. It doesn't discriminate. Each picture here shows someone that may be brain injured. We have someone on our team that has she'll talk about how she has facial paralysis, and that would be the only reason you would know anything was going on. But you wouldn't actually ask someone normally what happened, perhaps. So that's the issue with, dealing with brain injury as a survivor or even as a family member, trying to talk about it, and vocalize it and how to go from there. So about brain injury, there's a huge umbrella of brain injury called the acquired brain injury, and that is an ABI. It's a disruption in normal brain functions caused by an external or internal force to the head. Next. And so then underneath that umbrella, there's the non-traumatic brain injury and then the traumatic brain injury. And so as many of you know, I just want to recap that a non-traumatic brain injury is an internal change to the brain, loss of oxygen, chemical changes, disruption of blood flow, tumors, or a stroke. Whereas traumatic brain injury, or TBI, is an external hit or blow to the head, mild, moderate, or severe based on loss of consciousness, brain scans, or levels of alertness. And, we like to go over these different types because a lot of people, it's in the news, it's very known what TBI is, and a lot of people think about TBI when they hear brain injury, but there's a non-traumatic brain injury as well. So we want to get more awareness on that. So brain injury can be temporary or a lasting condition. One brain injury we want to talk about is a concussion that Dr. Modi will talk about further, but it can be blacking out less than 30 minutes. Often normal brain scan results commonly done in emergency departments, such as a CT, confusion or altered mental state or disrupted memory, less than 24 hours. Symptoms commonly overlap with post-traumatic stress. So my time with veterans, as Tim mentioned, there were a lot of coexisting conditions with PTSD and TBI. So we had to really sort through those and figure out resources. A little statistic is 10 to 15% experience long-term symptoms, and repeated injury increases risk for longer recovery. Is that all of our slides? Okay, so Brad was going to take over for discussing our resources that we provide, and he's going to share our website and go through that.
Well, good afternoon, everyone. My name is Brad Blackwell, and again, I am the Statewide Training Coordinator with the Brain Injury Association of North Carolina. I've been with BIONC, or Brain Injury Association of North Carolina, since January of this year. What I'd like to do is share my screen. Here we go. And what I'd like to do is just spend just a minute just to direct everyone to our resource directory. If you visit our BIONC.net, that's BIANC.net, and click on Resource Center, you'll be directed to our resource directory. And on our resource directory, we have just an amazing amount of resources. And again, I'd like to remind everyone that the Brain Injury Association of North Carolina, we are a statewide organization. So our resident to try is to provide resources to all North Carolinians around, as Alicia mentioned, acquired brain injury. So I just wanted to point this out. So you can search any of the categories, and as you can see, we have just a number of categories here. And also you can search through location. You can, sort of modify that to find those resources that are closest to you, and just search. So for instance, if you're looking for neuropsychiatry, and we'll just type in North Carolina, and let's do Raleigh, North Carolina, and search.
I was about to say your radius might be small.
Yeah.
Yeah, but it
Oh,
comes
here
up.
we go. I didn't scroll down all the way. Okay, I apologize. So you can see here, we now have listed um, all of the neuropsychiatry physicians, healthcare providers in and near the Raleigh area, and provides their phone number, their website, and their address, and how far it is from your location. So I just want to take a few minutes just to point out that and this is newly updated. This is our resource directory 2.0. So we definitely want to encourage everyone who needs resources, has questions, needs to find a healthcare provider, a day program, support group, so on and so forth. We have that information here for you.
Yeah. That's it for our section. There's also different things on Beyond.net. There's a toolkit. So just explore through the website as you wish. And thank you guys for listening.
All right, this is Ted again. Brad, Alicia, thank you so much. Really good information. We do have a question, and perhaps Alicia, based upon what you shared with us, you may be able to respond to this. And one of the questions is, if brain injuries are caused by medications, is that considered non-traumatic brain injury?
Yes, it is, because it's an internal situation. And I know Dr. Modi can also elaborate on that more than I could. So,
Dr. Modi, would you want
Sorry,
to respond to that and cut you
Yeah,
off guard
absolutely.
here?
There are several medications that can cause a brain injury, and directly or indirectly. And so, yeah, they would be non-traumatic brain injury.
And a follow-up question to that, because for the most part, we're talking about medications, prescribed medications. What about illicit drug use, substance use? Are there brain injuries involved with that?
Yes, absolutely. So the most common that we see is opioids, and opioid overdose causing cardiac arrest or respiratory arrest, and that causes brain injury. This was far more common a few years ago. It's getting better now, but that is the most common one. And alcohol is another common one, which can cause chronic brain injury. In diabetic patients, accidentally taking too much insulin can drop blood glucose and can cause brain injury. So that is another common one that we see. Yeah, if that answers your question.
Yeah, thank you, Dr. Modi. Alicia, one more question to toss over to you, and then looks like we've got a couple other questions coming in. Dealing with veterans and tapping into your experience there. There, I think, has been some myths out there that every veteran with PTSD has TBI, and every veteran with TBI has PTSD. How would you break that down for us to better understand that?
yes, in my time working with veterans, my initial, I guess, service was to provide housing. And along with that, we had screening tools. And, you know, they are connected to, most veterans are connected to the VA. And so, or a VA hospital. And so they do screenings there as well. And not all veterans have TBI, not all veterans have PTSD, but there are different screenings for each. And most times there are some coexisting issues there because, you know, if you have TBI, that could, you know, increase symptoms of PTSD and vice versa in terms of the recovery process. Yeah, they're not both they don't always have both. So there are screening tools involved at all resource locations for those two separate situations.
All right. Well, thank you for addressing that.
Thank
During our time here, we did come up with a few other questions. One is, how can you determine if someone has a non-traumatic brain injury?
Yeah, and I'm definitely not a doctor, but Dr. Modi can explain that further, but they're
Yeah,
definitely.
that's usually based on the history.
Yeah.
That's usually not the question, and what your story is
Yeah.
what the cause is.
Okay. And one of the other questions said, I want to confirm, you said that all brain injuries are caused by medication. So I'm not sure about the clarification with that. But there's, like you said, Alicia, there's the external brain injury, and then there's internal things that happen that result in brain injury too.
Yeah.
Okay.
Definitely.
How about this one? Can a traumatic brain injury exacerbate someone's mental health?
Yes. Especially if there are pre-existing conditions as well. And it can definitely affect the recovery. It can also, as someone recovers, can come out in different ways in terms of mental stability.
Okay. Another question is, approximately how long does it take to recover from a brain injury?
Dr. Modi, if you can handle that one.
I was going to talk about that. That depends on the age and severity of the injury and general medical conditions. So these three variables. Most of the mild traumatic brain injuries, they recover within few weeks, and some severe traumatic brain injuries and non-traumatic injuries, they take months and years, and a number of times it doesn't completely recover.
Mhm.
Okay, just a couple more as we have a few moments here. What are some of the symptoms that will alert you that you have a brain injury?
So I love all these questions. They're great questions. I think, Dr. Modi is going to discuss a lot of these questions, which in more in depth, but there are so many symptoms that varying. If I think you can agree, Dr. Modi, that it all, when you see one brain injury, you see one brain injury. So it could be different with each patient.
Yes, yeah, I will go over those symptoms in a little bit.
All right, fantastic. And then one final question, and then we'll be able to move on. And that's, do you use functional MRIs to determine non-traumatic brain injuries?
Yes, we can use functional MRIs. They are more for some. I would say more for research purposes, and in some cases medical legal purposes. But yes, we can demonstrate brain injury on the brain MRI, functional MRI, and it's usually not used in clinical practice because it doesn't change management so much. So it's more for research and medical legal purposes. Although these things might change in a few years as these technologies are becoming more and more available.
All right. Well, thank you all for your responses. And back to you, the audience. Thank you for your questions. We appreciate that. Next up, we are going to hear from Pierre Protz and a personal story. and also including some tips on communicating with health professionals. So Pierre, if you're ready, go ahead and take it away.
I am. Thank you. Such a pleasure to be here with everybody. And thank you, Anne, for inviting me to be here to share my story. This journey with my brother Eric began, if you can believe it, 59 years ago. His accident was in June of 1964. And I've always called that the dark ages of brain injury research and neuro medicine. It's hard to imagine that it's been that long, but through that time frame of 59 years, Eric has gone from age 15 to now nearly 75. And we have seen so many changes, both in Eric, thankfully, but in medications, surgical practices, and procedures, of course. And we've seen how wars have created new research opportunities into brain injury treatments and technology. And we have seen how the study of pro football players in their later years have revealed changed behaviors, sometimes violent, relationship problems, terrible confusion as their health has been compromised by repeated concussions taken on the field of play. And of course, that's known as CTE, or chronic traumatic encephalopathy. And so therefore, our student athletes have very much benefited by those studies, because they're now monitored more and they're taken better care of when they're injured on the field. And we've seen Hollywood take an interest in spreading awareness by producing movies like 50 First Dates and Concussion, and other ones, many others that have highlighted brain injury and its effects on individuals. But brain injury is harsh, and it can be very sudden and unexpected. And no one saw my brother's accident coming. It was so totally unexpected. 1 minute, life was normal and good, and the next minute, in the blink of an eye, things changed forever. For our family, everything changed. Eric and Dad were on their way to a scout meeting that June evening in Dad's pickup truck, and we'll never know exactly what happened because Dad had his eye on the road. But we think that a piece of trash that was wafting around in the bed of the pickup truck had caught Eric's attention. You know how air currents can make paper fly if there's anything there. And we think that since Eric was such an anti-litter environmentalist type, even at the tender age of 15, that he thought he could open the door and reach out and grab that piece of trash. And of course, you know what happened. The rest, they say, is history. He leaned out involuntarily and the door struck a post on the street and came back on his head. And he had three skull fracture, many broken facial bones and teeth, and he ended up with paralysis on his left side. That night he had countless seizures. They never expected him to make it through the night, much less through the 7 months that he was in a coma. Eric was in the hospital for over a year, and he had to learn how to do everything over again. We were thankful for our friends and family that came to encourage him, because their visits did make him want to work harder to get better. But his old friends melted away. You know, 15 and 16-year-olds don't do well with tragedy like that. And so it was just easier for them not to be there for him. But he was not the Eric that I knew when he came home either. He was mad all the time. I thought he was mean because he yelled a lot. Of course, I was only 12, so those were my impressions. He tried to jump out the second floor bedroom window twice. For years, we all walked on eggshells because any kind of word might trigger a bad memory for him, whether it was him remembering situations where he felt that people would make fun of him because of his injury, or trying to discriminate against him because of his injury. And there were times we had to remind ourselves Eric wasn't mad at us. He was mad at life. So he sought comfort in his science, chemistry, physics, biology, geology. He returned to his laboratory in the backyard and surprisingly didn't blow anything up. And he was eventually able to go back to high school, and he graduated. The library was his favorite place because it was so quiet there and there were so many books. He didn't have a lot of friends. Kids thought that he was strange. After his accident, he spoke with a British accent, and I thought that was weird myself. But anyway, they tried to cast him as Henry Higgins in one of Myers Park High School's plays. But that didn't work out because his memory wasn't good enough to remember the lines. So he lost a lot. He was just shy of brilliant and being brilliant in the sciences, and his hero was Albert Einstein. And he wanted to do things that he was realizing he'd never be able to do. Become a scientist, make great discoveries, or even just work in a lab someday. His short-term memory was toast, and his long-term memory was far better than ours was. And that was probably a mixed blessing because it made him remember so much about what he had done. I'll always remember how my parents grieved because they had suffered a loss as well. But he did eventually go to work. He worked totally by himself in the receiving department of Lance Incorporated in Charlotte. And that was really the perfect job for him because he was not involved with other employees and he could just concentrate and do what he needed to do. So today, 59 years later, Eric lives with me. He and my mom moved in with me about 3 years before she passed away in 1995. He was happy to be here and has since become involved with our local coin club. And over the years, he's volunteered at the library as well as at Meals on Wheels, where he counts the money that comes in from the people who are recipients that send their money in for their meals. I was able to access a very good psychiatrist here in Goldsboro, of all places, that was familiar with appropriate medications, Dr. Modi, for brain injury, and Eric Protz became a much happier person. And his mood remains stable to this day, even though we have taken him off most of those drugs. Were there support for brain injury survivors in the 60s and the 70s and even the early 80s? I was never aware of any. Most medical professionals knew very little about brain injury back then. 59 years later, Eric still doesn't qualify for any day supports through Medicaid because he doesn't qualify for Medicaid. He makes too much money, but he and I'll make it. But I say to myself every day, what about the thousands of people in North Carolina that desperately need these supports? Survivors who get discharged from the hospital when they are deemed medically stable, sent home to families who have no idea what to do to care for them. And this is no slam against Cara, because obviously they have it going on at Carolinas Medical. But this is not the situation all over our state. Those families are plunged into this abyss of uncertainty, mostly without anyone to guide them through this complex system of care that we do have. It's complex, y'all. It's hard to navigate it if you don't know what you're doing. So I talk to these people every day in working in admissions for a provider of brain injury rehabilitation here in Eastern North Carolina. And the bottom line is that the brain injury community in our state is still suffering after all these many years. Brain injury has so many needs in our state. Increased funding for residential and community-based services is certainly on that list of needs, but there's a huge need for a quality system of public neurobehavioral events that go all the way across our state, where survivors in crisis can receive expert and professional care that's specifically geared to brain injury. Places that will keep you until you're better, not just send you home after 3 days or 5 days. And we also need a continuum of care for survivors as they progress to a better life. In North Carolina, it's predicted that over 80,000 people will sustain a traumatic brain injury this year. And that number doesn't even include the anoxic brain injuries that y'all were talking about early, such as stroke, heart attack, non-fatal drug overdoses, brain aneurysms, and other events that deprive the brain of oxygen. So these numbers will continue to grow every year, y'all, because of all these medical advanced procedures and surgeries that save more and more lives every year. So what will we do as professionals to encourage the continued growth of funding in order to meet these needs? Because people do get better and people do live longer. And if they're given the opportunity and the tools to do so, they can be happy. I know I'm supposed to talk about tips on communication with healthcare professionals. Sometimes that is not an easy road. So many people do not, in the healthcare profession, do not understand brain injury. In most cases, you have to teach about communication deficits as you go along. Excuse me, about whether the individual has aphasia or not, or poor memory or poor speech, and it makes it difficult for them to understand. Often these professionals need to know that survivors don't always display the same symptoms that we do when we have problems. And they, of course, they may not be able to verbalize exactly what it is that's hurting. A UTI is a classic example of that. So many survivors don't display fever or pain in urination or any of those things. Confusion is probably the cardinal thing that a survivor displays if they have a UTI. And I remember that one of our residents was hospitalized for pneumonia once, and he was receiving very little attention on the floor of the hospital where he was. And I spoke to the PA that was working his case that day. And this gentleman explained to me that the average brain injury survivor will not live more than 5 or 6 years after injury. And our patient he was already 12 years post-injury. So I think this is a misnomer in some cases. People do live for a long time. Look at my brother. So just to emphasize the fact that there is a lot of misinformation out there still, even after all this time. So thank you for letting me be here. I'm enjoying hearing all of these other folks speak, and it was my pleasure to be here.
Yeah, so I'm going to look at everybody right now. Throw some reactions up there. Kudos to you. My heart goes out to you, Pierre, as others are here also. And thank you for
Oh, you're
sharing
welcome.
what you shared and being
Hearts
there
galore.
for all these years. No doubt your advocacy work is being heard. And so if anybody can help make change, we need more of you. So we've got some thank yous tossed up in there in the Q&A as well. Awesome. All right. So folks, we are real close to hearing from Dr. Modi. However, before we get there, I believe Ann Gluff has something to share with you. Ann, are you all ready?
I am ready. Beth, you want to bring the slide deck back up? So I thought one thing I want to say is thank you so much to those who have spoken already. A special thank you to Pierre. What a great story. What a success story for your brother. And I love how you shared that each individual is different and so important for us as caretakers to advocate and teach as we go along. So what a great message. So right now, just for a little break, we wanted to do a quick giveaway. So if anybody out there likes to win a prize, now is your time. I'm going to give one caveat there. If you're a partner's employee, I have pulled your name out of the hat. And so what I'm going to do right now is I am going to ask Ted to pick a number between 1 and 23. And if I could do a drum roll, I would while Ted's picking a number. And so Ted, you want to throw a number out for me?
Okay, some of you may get this reference, maybe not. I'm going to put this, what should be an envelope, up to my head to pick a number, right? And I pull that number out of the envelope. Those of you who are old enough to know what that means, Yes, there you go. That reference to a late night show. And that number actually that I wrote down just a few moments ago, which is it's interesting that you said between 1 and 23 because the number is 23. And the reason that I chose 23, even not knowing that there were that many people here, was that as a combat veteran, I worked alongside someone in the Gulf War who was indeed 23 years old and sustained a traumatic brain injury that seriously impacted his life. And so the number is 23. So what do we have? Do we know
All
who
right.
that is? Or are we going to
So in
announce them?
honor of number 23, I'm going to announce that Akela Dry is our winner. So Akela, I hope you are still online with us. I think you are. And your prize is the Partners Travel Umbrella. And so what I'll do is reach out to you. I have everybody's email from registration. And I'll reach out to you to get a good mailing address for you, and we'll get that out to you. So I'm going to throw it back to Ted, but we do have one more that we're going to give out before we end our session today. So just wanted to let you know that hang around, got to be present to win. And we have one more item. It's different than this one. So I'll see you back then. It's all yours, Ted.
All right. Thank you, Ann. This is an exciting part of the program today. We often don't get to do this in some of our sessions. So that is a beautiful umbrella. Not trying to push it, but the orange is Clemson Tigers color. So I'm just saying, I know it's Partners, but I'm down here by Clemson, South Carolina. I know my orange. Anyway, so yeah, we are, as I said just a moment ago, we are ready to hear from Dr. Modi. And let me tell you a little bit about Dr. Modi. He is a board certified neurologist with interest in treating migraine, chronic headaches, strokes, cognitive disorders, epilepsy, concussion, and traumatic brain injury. He's an internal medicine specialist in Raleigh, North Carolina, has over 12 years experience in the medical field. Dr. Modi has extensive experience in epilepsy. He graduated from BJ Medical College in India in 2010. He is affiliated with medical facilities Novant, Forsyth Medical Center, Novant Health Presbyterian Medical Center, and his office is accepting new patients and telehealth appointments. And so with that, Dr. Modi, please share with us.
Yeah, thank you, Ted, and I, I like to thank everyone for the invitation. And just a little correction, Ted. I actually have left Novant in April, and I'm in running a private practice neurology office in South Park, and I also see patients over telemedicine throughout the state of North Carolina, and telemedicine is actually a very convenient way because what we have noticed is that patients have a lot of transportation issues. They have some of them have disability. Sometimes they don't have a car because they lost their car in an accident, and so on. So yeah, thank you so much. And I'm gonna start and just gonna go over types of brain injury. We briefly discussed that brain injuries can be non-traumatic and traumatic. And what you're seeing on the screen is the kind of traumatic brain injury that happens in wars and blasts and automobile accidents and contact sports, football, soccer. And the traumatic brain injuries is much more common out there in the community than the non-traumatic brain injury. I'll quickly talk about the non-traumatic brain injury first. The most common causes of damage to the brain are stroke, and they can be what we call as ischemic stroke, means blockage of blood vessel in the neck or the brain, and the tissue supplied by that blood vessel, it kind of dies. And the other type of stroke is a hemorrhagic stroke, where blood vessels in the brain bursts and the blood is released, damaging the tissue around it. The blood is also kind of toxic if it's outside the blood vessels, and the tissues get damaged because of that. And as Pierre mentioned out, some infections, they are also common: UTI, pneumonia, COVID infections, flu. We see all these patients, especially if the infection is severe, it can cause permanent brain damage. And these patients need attention to their brain damage, rather than what happens in the hospital is these patients get restrained and they're given medications to just sedate them, and rather than going with all these approaches, I think the community in general needs to know that it's very common for brain involvement in infections. Other causes of non-traumatic brain injury are cardiac arrest. It happens commonly after a heart attack, and there are some other causes. The brain doesn't receive blood or oxygen, and it can cause like a diffuse or global brain injury. Opioid epidemics. When I was in Detroit a few years ago, we had I personally had like at least a couple of patients every day in the ICU from opioid overdose, and opioids suppress the breathing, and that causes deprivation of oxygen into the brain. And nowadays we don't see it that often. It has dropped significantly, I would say. Alcohol is another common cause, although it's on a slow decline, but it can cause chronic brain injury. Some other drugs like cocaine can cause stroke and brain injury, and so on. And now I'll talk about the traumatic brain injury, where there's an external force. The common ones are, in children, it's sports and falls from the stairs and trampolines and whatnot. And in younger adults, it's usually automobile accidents, car accidents. And in older age, it's usually falls again, especially after the age of 70 and 80, which are very common nowadays. So that's just a brief overview of traumatic brain injury. So you can see on the screen here, and what happens is our brain, it floats inside the skull in water. It's not actually water, it's called cerebrospinal fluid, but it's 99% water. So the brain is floating inside the skull. There's a tiny little gap around the brain, between the brain and the skull, so the brain has some room to move around. And the purpose of this fluid is to protect the brain from small blows here and there. But if there's a big blow, then if this hand is a skull and this is the brain inside, the brain can have an impact inside the skull, and brain can impact back and forth. And so usually in something like a fall or car accident, we see like a trauma in the front and back of the brain, both at the same time. Next slide. Okay, this is, I wanted to talk about this picture. It shows different lobes of the brain, and they have different functions. So the yellow part is the frontal lobe, and the frontal lobe is the highest evolved part of the brain. And humans' frontal lobe is far more evolved, and it has all the higher functions that separates us from other animals. And these are attention, concentration, execution, and controlling our impulse and controlling our emotions. The lower animals, you know, like chimps and mammals and dogs, and they have their behavior is more driven through their emotions, but humans have this highly evolved frontal lobe that can suppress and control the emotions and think logically. So that's a function of the frontal lobe. And you see the other parts of the brain. The pink is a parietal lobe, and its function is processing of sensations, that incoming sensations. So touch sensation, smell sensation, taste sensation, and things that we hear. This is the parietal lobe performs like a higher level processing of these functions. And then the purple is the temporal lobe, and temporal lobe has memory functions, and the language function. And all the way at the back is blue is occipital lobe, and that does vision processing. And the red part is the cerebellum, and that has a balance and coordination function. So overall, the frontal lobe is the most prone to get damaged, partly because of its location. It's at the tip of the brain, and partly because it's the most evolved function of the brain. So it's least resilient to the damage. Other lower functions of the brain are more resilient to damage, and they can recover easier. But the highest evolved functions of the brain in the frontal lobe, they are more susceptible. They don't recover as well as the other parts of the brain. Okay. Next. Okay, so just brief overview of like a most common traumatic brain injury. And headaches, brain fog, problems with sleeping, because somehow the brain damage can alter the sleep architecture. Dizziness, balance problem by damage in the cerebellum, the back of the brain, or from the balance centers, which are inside the ear, internal ears. Problems with vision, because sometimes the back of the brain is involved, and then comes mood changes, which is also part of the damage to the frontal lobes, because they can control our mood and our impulses. And the frontal lobe also has a personality. Everyone has a different frontal lobe. That's why all humans have a unique behavior, and so the personality can change with damage to frontal lobe. Okay, next. Okay, so common causes, common symptoms. I'm going to go in more details. Headaches, very common. It happens because there's a trauma to the head. There's a thin layer of muscle around the skull, and any blow to the head can cause inflammation in parts of this muscle. This muscle can go into spasm, and that can cause like this pressure sensation, sensitivity to light, nausea, and blurred vision. And this is many of the patients describe after having a concussion and brain injury. So they're having a lot of headaches, and they feel like there's a lot of pressure. They feel like they're underwater, or there's something heavy on their head. Okay, next. Okay, problems with sleep. So in a non-traumatic brain injury, this is a bigger problem because there's a lot of disruption in patient's lifestyle. They are many times not independent. They're not living in their home. Maybe they might be in the hospital or rehab for a long time. And that change in routine can cause disruption in sleep. So they're not going to have like a good 7 hours of sleep every night. So that's one cause. Another cause is there are sleep centers in the brain, and it's very complex how they work. We still haven't figured out completely, but they get damaged when there's a generalized damage in the brain, like after a cardiac arrest, there's a global damage to the brain, or after a car accident, there's a diffuse damage to the brain, and the sleep centers are actually damaged, and that disrupts the sleep architecture. So they have a hard time falling asleep. And then after they fall asleep, they don't stay asleep for a number of hours. They keep waking up. And this is important because sleep helps with recovery of brain, recovery of brain functions, and recovery of mood. If it's like a double whammy, you get a brain injury and then you lose your sleep, which helps to heal the brain injury. So sleep is very important, and we have to address that. That's how doctors often think. First thing I see a patient is address their sleep in a brain injury. Okay, next. Okay, cognitive deficits. Again, as I mentioned, the frontal lobe is the most susceptible to brain injury, and it has functions of attention, concentration, and execution of tasks. So, children in school, they have problems with academics, and young adults, they have problems at their job, and then if they have children, it becomes overwhelming because whoever has children, they can imagine a life where they're working and handling 1, 2, 3 children, and that requires very high level of attention span and impulse control. And then in older individual, they have more problems with mood control, and since they are not in college or school, they don't have to worry about academic performance, but they have to worry about their activities of daily living and their relationships. If they're having cognitive deficits, then it does affect their spouse and other family members. So this is very important. Okay, next. Okay, dizziness. So dizziness can be 3 types that patients usually describe. The one type is feeling lightheaded, feeling like a head rush. So when you change body position, the blood pressure drops in the head, and their cardiovascular reflexes get weaker. So they get dizzy for a few seconds. They feel like they're going to pass out. And usually it indicates a deconditioned cardiovascular system, and they basically need more physical activity and rehab, so to train their cardiovascular system again, so the blood pressure doesn't drop that often. So that's one description of dizziness. There are 2 more. The second description is feeling of vertigo, spinning sensation, and that happens from damage in the internal ears, which are embedded in the skull bones. It's it's considered part of the brain because they're deeper, and they sense their balance organ. We call them vestibular organs, and they sense the balance and orientation and motion. And in a brain injury that often gets affected, especially in a concussion in children or car accidents, and that can cause this episodes of sudden vertigo and spinning sensation that lasts for a few seconds, and then patients have to pause and wait for the episode to resolve, and then they can go back to their business. And the third description of dizziness is feeling as if you're walking on a boat, and that is more complex to describe, but it can happen from the same reason, internal ear damage, or it can happen from damage to cerebellum, the balance part of the brain. And the balance is also associated with visual fixation, in the sense that we all know that when we turn our head, if we are looking at someone and we turn our head, our eyes can focus on an object. So this process requires a good coordination of brain and internal ears, and this is affected. So when the patients have a hard time focusing on an object when they're moving their head, and same thing when they're driving or when they're in a moving vehicle, they have a hard time fixating on an object outside. Sometimes they get motion sickness. Next slide. Mood problems. These are usually the least addressed problems. I think when patients come to their doctor or a therapist, because it's very hard to tease apart, and the providers, the healthcare providers, have to actively ask the patients about all these questions. Otherwise, patients are not gonna come and say, hey, I have problems with emotional outbursts. They might think this is just their new personality, and they might get used to it, and their family and friends might get used to it, but they're not gonna actively go out there and seek help with a lot of these things. Being irritable, angry, depression, suicidal thoughts, like as Pierre mentioned in the story, that was very classic. Anxiety is very common, going back to the playing field or going back to their cars. They have anxiety. Personality changes. One of the most common things that I found in personality changes is people become isolated. They avoid socialization, and that makes the things worse, because if you're not going to talk out about your emotional state, then you are less likely to get help, and other people are less likely to understand you. Okay, next. Yeah, so this is the picture of the vestibular organs in the ear that I was talking about. The purple part is we call as internal ear. It's embedded in the skull bone. And see that spiral portion is the where we sense the hearing and vibrations, and so damage to that part can cause hearing loss and tinnitus, like constant ringing in the ears. And you see the upper part, those three loops there. That's called semicircular canals, and they are the ones that sense motion, balance, line of gravity, and how your body is aligned to it. And so damage to those parts can cause vertigo and dizziness. Next. Okay, so this is just quickly going over some pictures and scans. this is a CT scan, and you can see the brain, which is gray, and the skull bone is that white circle. And if you see in the brain substance, there are some white lines that all indicates blood. So this can happen in a brain hemorrhage, and even strokes like ischemic stroke, and this commonly happens in a concussion or traumatic brain injuries of other kind. And this is what the doctors are looking for when patients come to the emergency room and get a CT scan, a hemorrhage in the brain. So location of this hemorrhage, how severe it is, that dramatically changes how the patient is going to be managed. And from any kind of brain injury, if there's a loss of consciousness, vomiting, paralysis on one side, speech problems, bleeding from the ears and nose, running water discharge from the nose or ears, these are all concerning for strokes and severe concussion or severe traumatic brain injury. So this is a brain MRI, and you see the black spots here. It shows areas of blood and iron. Iron deposits in the brain would look like this. So brain injuries from lack of oxygen or cardiac arrest or trauma like accidents and concussions, those forces are, as I mentioned, they're usually in the frontal part of the brain, but they may not be. The force can transmit it throughout the brain. If there's a cardiac arrest, then the entire brain will be deprived of blood flow and oxygen. So some blood vessels get damaged and they leak blood, and we can see that blood as iron deposits and in this tiny little spot throughout the brain, because blood has hemoglobin and it has iron. So any kind of metal deposits will look like this, and this will stay there for the rest of the life. Iron can't be extracted from the brain easily. So we can tell if there was an injury in the past based on the scans like this. And this is another MRI. It's a more advanced MRI we call diffusion tensor imaging, DTI, and it shows the cables, the white matter, the fibers of the brain that connects neurons. So neurons are the nerve cells, and they're scattered throughout the brain, and they're connected in a way like billions and billions of connections that makes all these circuits. And you see on the left side is the imaging that looks normal, and on the right side is the damaged brain. So this happens in an anoxic brain injury where the brain was deprived of oxygen, in a cardiac arrest or opioid overdose. And this can also happen in a diffuse brain injury in a motor vehicle accident. The important thing to know is that although you can demonstrate that there is a lot of damage and loss of fibers in the brain, that doesn't always mean that patients can't recover. When the brain turns from this left side normal brain to this right side brain, it can't go back to the left side. The brain fibers and cells can't regenerate after the age of 2 or 3 years old. It's very hard. But this circuits, even they are less and with less connections, they can adapt, and extensive therapy for months and years, you can train the brain to function with a less amount of circuits. Similar things happen when we age. If you take an MRI, a DTI of someone who is 20 years old, their brain will be full of all these circuits on the left side. But if you take an MRI of someone who is 100 years old, their brain will look more like a lot of loss of neurons and nerve fibers. But as you know, many 90 and 100-year-old people are very highly functional, and because throughout their life they constantly learned, and their brain constantly adapted and learned. So even if there's a loss of a quantitative loss of fibers and neurons, qualitatively their brain might still be better. Another thing is that there's a endocrine organ, pituitary gland, in the brain. It is called the master of all the endocrine glands in the body. They control they can release chemicals that can control other glands like thyroid glands and adrenal glands and gonadal hormones and all that. So this pituitary gland is considered part of the brain, and it's usually damaged in very severe brain injuries, and usually not in mild brain injuries. So we sometimes test hormones, and patients can have hormonal problems like growth hormone problems and thyroid problems and sex hormone problems, etc. Okay, next. So this is another testing. Seizures are very common. So seizures can happen immediately after the brain injury. When there's a brain injury from a stroke or a hemorrhage or a trauma, the injured part of the brain can swell a little bit, just like any other body part would swell if it's injured, and that swelling can trigger seizures. And then after a few weeks and months, the swelling will go down, obviously, but then that tissue can turn into scar tissue, and that scar can cause seizures also. So the seizures from the scars are more difficult to treat and control than the seizure that happen initially from swelling. And we do this EEG testing, record brain waves, and sometimes we have to keep in mind that seizures are not always like what people have in mind. When people think about seizures, they usually think about whole body jerking, losing consciousness, biting tongue, and all of that. But seizures can be very subtle. And those subtle seizures are usually more common than full body seizures in brain injuries. Subtle seizures are often like absent-mindedness. People snap out of concentration. They have a blank stare into space. Sometimes they have a little twitch on their face or their hand, and then they snap out in a few seconds, and they don't have a recollection of what happened. They don't even have insight of that something went wrong for 10 seconds. So in that case, their family and friends, they can be a good source of information. Move next slide. Okay. So treatment, I'm going to talk about more like a milder brain injuries than severe brain injuries, because the severe brain injuries, their management is very complicated, and it's not as simple as mentioned here. But milder brain injuries, which are very common, concussions, it's time to take it easy. I would say just stop pushing yourself and do what you like, and you don't have to do like a math puzzles and stuff to make a good recovery. if you can just be yourself and do what you like for some period of time, then the brain can recover better. The brain recovers best when patients are not under stress or so these are the simple things to keep in mind. Next. Okay. Again, these are milder brain injuries and headaches, usually treated by over-the-counter medication. Sometimes like over-the-counter magnesium helps. It's like a natural muscle relaxant, and it can relax some neck and head muscles a little bit, so that helps. And of course, if it keeps going on, then just need to see a neurologist. Next. Neck pain, very common, from being sleep deprived, from having a blow to the head, and that needs some exercises, physical therapy. Some people go to chiropractor, and some pain management doctors can help with that. Next. Okay. Dizziness, as I mentioned, if it's a lightheadedness kind of dizziness, then you need more hydration, maybe a little bit more salt in your dietary intake, and some minor exercises, I would say light exercises to keep your cardiovascular system active. And vertigo needs vestibular exercises. Vestibular therapy can help with that. Next. Ringing in the ears, hearing loss, need an ENT doctor, ear, nose, and throat doctor. Sometimes white noise, like the background noise, like a running fan, that kind of noise helps. Next. There's blurred vision, which is common. It can be from the damage to the back of the brain, occipital lobes, where the vision processing is, or it can be damage to the eyes. So see an optometrist. Next. Concentration problems. So initially, when there's a brain injury and you're in the hospital, and then maybe in rehab for some time, patients don't have to worry about this concentration problem. It becomes an issue when they are, they're trying to get back to their life and their occupation and their college and whatnot. So there are medications that can help, that we can prescribe for a few weeks and months, maybe years, that can help through some difficult times. And cognitive behavioral therapy that psychologists and neuropsychologists can help with, that can also dramatically improve concentration. So it's always a good idea to seek for help. Anxiety and depression are very common, and depression actually affects cognitive performance. So some of the concentration problems can be from just being depressed. And the healthcare providers are usually very vigilant in asking these questions actively, because patients are less likely to come to the doctor and present that they have some depression problems. Next. Okay, and as someone asked in the Q&A that how long it takes to recover. Well, that's a very big question. Depends on what was the cause of the brain injury, how severe was it, what is their age, and if they have any chronic medical problems. So in general, younger people are far more likely to recover. I mean, I have a long time ago, I have seen pediatric patients in 5 and 10 years of age going through extensive ICU stay from a brain injury, and after 2-3 years fast forward, I see them in the clinic and they're like almost completely normal, and as you grow older, the brain is not that plastic, but still there's a lot of room to improvement with longer therapy and more intense therapy. And chronic medical problems are always a big challenge, especially in older demographics. Yeah, I guess that's it. Is that the last slide? Okay. Yeah. Any questions?
All right. Yeah, tossing some applause out there for Dr. Modi. Thank you so much for bringing all that information, breaking it down for us. Very informative. We do have a couple of questions. Yeah, I do want to mention up front though that of course this is being recorded. We're going to make available to everyone a PDF of the PowerPoint, so all contact information and everything and all the details would be put out there. But this being recorded, we're also going to give us about 10 business days or so to get this posted under the member tab of our partners website. So you can be on the lookout for it there and share it, family, friends, wherever you want to make that happen. So question wise, there's one asked, said, if the injury affects cognition and speech, what is the best way to treat psychological mood issues? Is neurofeedback effective?
Yes. So, yes, as I mentioned, it affects cognition and speech, very common. And I don't know, that question disappeared, but oh yeah, it's here. Sorry. Yeah, it's very common to have these problems, cognition and speech problems. The best way to treat them are first, seeing a psychologist and a neurologist. So a psychologist can start cognitive behavioral therapy, and neurofeedback or neurobiofeedback it's kind of part of it, depending on how you define it. And the neurologist can use medications to help with that. And there are a lot of options, if someone has mood problems, then again, that can affect indirectly cognition and speech. And that can be treated by psychiatrists or psychologists, again, with cognitive behavioral therapy and some medications by psychiatrists. So it takes a village to take care of all these multiple problems.
Yeah, it sure sounds like it. And I can, based on what you said there, it's easy, I think, for us to pull together where this potentially physical thing happened, and it have a direct impact on people's mental health, behavioral health. So I appreciate you addressing that. One other thing that we wanted to touch on here was perhaps you could speak for a moment about how do doctors manage pain issues now versus, say, a decade ago?
Yeah, so chronic pain has evolved significantly in last decade, I would say. When I was in my fellowship and later in residency, we had I would say half of the patients were on opioid medications, and we went through all this opioid epidemic, and there was a crackdown on this medication prescription. And what we see now is that far less patients are on these medications because they're not asking for it. Opioid has never been a long-term solution for pain, and patients and providers are realizing that. And the pain is approached in a different manner now. Lifestyle modifications like exercises, physical therapy, cognitive behavioral therapy can also help with some chronic pain patients. And when medications are prescribed, they're usually non-opioid medications, and they are effective. So there are a number of options. You might be familiar with things like Cymbalta, Elavil, Pamelor. And there are some more spinal cord stimulator, which help with the neck pain, injections in the back of the head, occipital nerve blocks. It has evolved significantly, and it's always a good idea to tell your provider that you are in pain, and they'll go over these things. Yeah.
Fantastic. Thank you, Dr. Modi, for responding to that. We appreciate you being here and sharing everything. So again, applaud to you. We do have a couple more things going on here. And at this time, I want to bring in another personal story. Jean Anderson, she's going to share with us. Jean has a personal story herself, but sharing some tips, communicating and such. But she's also part of our what we call CFAC. That's the Consumer Family Advisory Committee. And so anyway, Jean, if you're ready, we'd love to hear from you. You're muted, by the way.
Good point. Thank you, Ted. I appreciate that. And I appreciate the opportunity to be here today. And I'm thankful for everybody on the panel today who's had some input, because it's really been a great podcast to listen to. So first of all, let me tell you a little bit, kind of the short version of my story. I have 7 children, and my youngest had graduated high school. So we thought we were about to be empty nesters. And he was in an auto accident. Sam was 19 at that point. He had the original traumatic brain injury. And then I know in the helicopter, his heart stopped. They believe he suffered an anoxic injury at that point. And then after months, we spent about a year in the hospital. But after several months and several types of recoveries and regressions, he had some infections that caused some problems. He had a stroke during a surgery, and then he had an infection that infected his skull and his brain, and lost most of his frontal lobe on one side due to that infection. And so when we came home, we had a son who was minimally conscious and was in the emerging from his coma. And what we ended up with was a situation they call locked in, where he was aware and could communicate with us through blinking his eyes. And he had some movement in one thumb, so he could work a switch. But for the most part, he was very, very affected by his brain injury. And Sam lived for 14 years with us at home that way, and passed away of a different physical issue. But it's interesting. His pituitary gland had been affected, and a lot of folks have issues with diabetes and other issues sort of subsequent to their brain injury, which is actually part of their brain injury, not a systemic diabetic issue. It was really interesting, and a sharp learning curve as parents. One of the things we discovered was there's no safety net. That safety net that everybody thinks is out there and will catch everybody and provide what they need to recover really isn't there. And the parts of it that are there are very difficult to navigate, as has been mentioned before. It's a very hard puzzle to put together to help someone to recover in the best way possible, and then to provide what services they may need ongoing. It can be difficult, and some folks find it frankly impossible to deal with. So a couple of the things I wanted to mention when we talk about the CFAC, it's the Consumer and Family Advisory Committee. All of the MCOs, like partners, have one. And it's a way for folks to let it be known what issues they're having, what's working well, what doesn't work, what barriers are there to folks receiving the care that they need. And so I really want to encourage people to, and this is for family members and people with brain injuries themselves, to, look into your local MCOs and see if there's a seat available that you can fill and represent your county and your particular disability. There's a lot of opportunities throughout the state and in each county to do this. There's collaboratives, there's all kinds of work groups with the Department of Health and Human Services. So it might take a little bit of looking into, and it might take contacting BIONC, the Brain Injury Association of North Carolina, to help you connect to some of those opportunities. They also, at BIONC, they offer support groups, both virtual and in person. And I really want to encourage family members and individuals with brain injuries to look into that. It can be quite helpful, and you might learn something that you hadn't thought of, on your own. One thing we found really helpful was keeping, I guess you'd call it's kind of a health diary, but just a list of interactions between medications and physical effects, behavioral effects, mood changes, between foods and those things, and situational things like noise, crowds, light and dark. And when you go and speak with your physicians about, whatever issues that are going on, be really frank and really honest, and tell them how you feel, tell them how your family member feels. And I want to encourage folks that are caregivers, family members at home, that you're part of this whole brain injury too. It has an effect on the family that reverberates to all the family members, and it will for quite some time. And it's important to be able to recognize that and seek help for yourself, respite for yourself. I think most folks refer to it as self-care. But that's my my hint for the day is self-advocate. If you request a service or a piece of equipment that is denied by your insurance company or whatever entity, appeal that decision. Tell them what you need and tell them why, and just don't take no for an answer. And hopefully everything will go well.
Wow, Jean, thank you for your story, and really pushing that piece of advocacy. And I just ask everybody here to throw up some love for Pierre and Jean for sharing like they did and coming forward with this. Dr. Modi, again, thank you so much for sharing what you did. And Cara, even though she had to leave, we're still throwing up some hearts and applause for her too. However, stick around, we're not done. We are at this place and time where I'm going to turn it back over to Ann. I have already written down a number, and she is going to give me the range. And so we're going to see who ends up now with the next item. Gosh, Ann, tell us what our next item is.
There I am, leaving myself on mute again. So the next wonderful, fabulous winner is going to receive a Partners stainless steel insulated tumbler. And I can vouch for this tumbler. I do drink my coffee out of it when I'm driving, and it keeps it nice and toasty, which I appreciate. So Ted, we're going to stick with between the numbers of 1 and 23, but you can't pick 23 this time.
On 23 is has already won their umbrella, so
That is
waiting
right.
for a rainy day there. However, I think number 10 needs this tumbler.
Number 10.
Number
Okay.
10, drum roll.
Drum roll for number 10. All right, Miss Lori Carlson is our winner. So congratulations, Lori Carlson. You'll be getting your tumbler mailed to you. I will connect with you via email to get a good address for you, as well as a Kayla Dry for the umbrella. And thank you all for spending your afternoon with us today. All right, Ted, I'm going to send it on back to you.
Yeah, likewise. Thank you all so much. Looking at your screen right here, if you're curious, you can take a screenshot of it. Of course, this information will come out to you as well, and it'll be available naturally at the end of the video if you want to look at that. But some great outreach here, and I recommend anybody to do some research on figuring out how to educate yourself. And these are some great tools and connections here. So if I'm not mistaken, let me see here. There it is. So if you have a phone, we want to hear from you. Or you can just simply use the link. But if you have a phone, put it up to the screen right there and take a quick shot of that QR code. It will take you over to our survey. We'd love to hear from you, get some feedback. It is important to us as we do these sessions. We learn from it, and we want to know what you think. So if you would, go ahead and take a moment to do that. Meanwhile, I'm going to say thank you all to our panelists, everybody that helped put this together. We love doing this for our communities, and it makes us better, and it makes you better. So with that being said, if no other panelists need to say hey, then we'll close it out. All right, I'm getting a bunch of waves. So again, thank you very much, everybody.